The following podcast is part of a certified educational activity titled Stories from the Pancreatic Cancer Casebook, Taking the Road to Improved Outcomes with Modern Therapeutic Concepts and Innovative Treatments. Access the entire activity and complete the post-test at peerview.com/RRU860. Downloadable slides and practice aids are also available.
Good evening, everybody. Thank you so much for coming. My name is Allison Ocean. I'm a medical oncologist, and I am a co-founder of Let's Win. And Let's Win is one of the sponsors tonight for this program, and we've partnered with PeerView, and we're very, very excited and honored to work with PeerView to advance the science and promote the information in pancreatic cancer. I started Let's Win about 3 years ago with a patient of mine who was diagnosed with stage 4 pancreatic cancer. And she was 60, she was jaundiced. She didn't even know she was jaundiced. She went to her dermatologist to get Botox, and her dermatologist said, "Your eyes are yellow." And she said, "What do you mean?" And that led to a diagnosis of stage 4 pancreatic cancer. And she went to a bunch of physicians, and all of them told her to get her affairs in order. "I'm sorry, we can't help you. You're gonna die very fast from this disease." And she was an executive in the PR world, and she said, "I'm not gonna take this information. I'm gonna change the message that patients get for pancreatic cancer." And all of her treatment was science-based and on clinical trials, and she lived almost 3 years with an excellent quality of life. And through her journey, we started Let's Win together. And Let's Win is a digital platform that promotes and distributes the latest scientific information, including clinical trials, research, and patient stories of success stories in pancreatic cancer, and all the latest research that's behind it. We always hear about the negative stories from pancreatic cancer. We don't hear about the positive stories and success stories. And that's the goal of Let's Win, to really let people know that we are making changes through this amazing research that's going on that you'll hear about tonight. And I want to show you now 2 videos. One is about Let's Win and how it works, and then the next video is a survivor's video. And again, I want to thank PeerView so much for giving us this platform to promote Let's Win and to really get the best information into the hands of those who need it the most. Thank you again.
When I was diagnosed with pancreatic cancer, I was shocked to learn that standard treatments are not effective long-term, and I was scared. I found Let's Win, which helped me create a personalized treatment plan with my doctor.
I use innovative, science-driven treatments with my patients and encourage them to visit Let's Win. Let's Win is an affiliate of the Lustgarten Foundation, the nation's largest private funder of pancreatic cancer research. We are a world-class community of doctors, researchers, and patients who share the latest science-driven treatments and research breakthroughs for pancreatic cancer.
Let's Win helps patients learn about their treatment options. Here's how it works. Under My Treatment, patients describe their experience. You can learn about innovative doctors and institutions who are currently helping other patients.
In clinical trials, we educate you about different types of trials to help you get clear and actionable information. You can share what you learn with your doctor and see if you can participate in trial. Under Promising Science, we interview leading scientists about their new research that may be helpful to patients right now. And our Managing Pancreatic Cancer section provides helpful tips so you can maintain your quality of life during treatment. The newsfeed keeps you up to date on new developments, and our videos inspire you with stories of long-term survivors. The resource library includes hundreds of helpful organizations, and our glossary helps you with hard words.
We want to hear about your treatment. Please share your story with us. You are not alone. Let's win together.
My initial reaction when I found out I had pancreatic cancer was surprise.
We all cried when we saw the doctor and they told me that I had 1 year to live.
I was told that my chances were not very good.
The literature that's out there contributes to the belief that this is the worst thing that can happen to a person.
I'm Cindy Gavin, founding executive director of Let's Win. Let's Win was born in May 2016 as an unprecedented platform to connect doctors, patients, and researchers with the latest science-driven treatment options for pancreatic cancer.
These cancer hospitals, they felt so sorry for me and they were going to help me die.
Last year, we launched a video series which features long-term survivors of pancreatic cancer.
Julia Gimon was my older sister. When she was diagnosed, went on the internet and was horrified. She thought about the language, how negative it is, and she wanted to shift that narrative. She found that there were some actually good stories and wanted to know how come people don't hear these good stories. And she had this idea of a video series.
The feedback was overwhelmingly positive and provided hope and inspiration to so many families. We are thrilled to be launching Let's Win Survivors Year 2. In the upcoming year, you will not only meet more survivors, but you will have the opportunity to meet the doctors and the researchers who are working tirelessly to create new and better treatment options for pancreatic cancer patients.
There's no question that the research being conducted by laboratories is having a real impact on patients' lives.
When I started working on pancreatic cancer research, there were very few people that were really dedicated to this problem.
There were fewer than 12 researchers in the entire country doing anything on pancreatic cancer. Today we can say that there's over 1,000.
Now there are actually targeted approaches that can help patients live for many years when before they would only live for a few months.
We have survivors now, not just 1 year survivors or 2 year survivors, but we're seeing people living for 5, 10, even 15 or more years.
I'm a 3-year survivor of pancreatic cancer.
I've survived stage 4 pancreatic cancer for over 6 years now.
And I'm a 6-year pancreatic cancer survivor.
I'm a 7-year survivor of pancreatic cancer.
I was diagnosed with stage 3 pancreatic cancer 10 years ago.
11-year pancreatic cancer survivor.
I'm a 15-year pancreatic cancer survivor.
I'm a 17-year pancreatic cancer survivor.
I'm an 18-year survivor of pancreatic cancer.
Let's Win Survivors is changing the narrative around pancreatic cancer.
Now when someone gets diagnosed, they can go online, they can see Let's Win, they can click, they can hear this story, and they can think, wow, I have a chance.
Instead of seeing grave statistics, they see life, they see hope, they see survivors.
They are the evidence that pancreatic cancer is not a death sentence.
This is not a death sentence. What you have to do is fight.
I took stock in the situation and said to myself, oh, what do I have to die for? And the answer was nothing. But what do I have to live for? It was plenty.
You can do this, and you know you can do this. It's one foot in front of the other. You're going to be able to handle this.
I wake up every morning and I give thanks that I still have 1 more day.
Well, thank you so much and welcome to everyone to this amazing pancreatic cancer continuing medical education stories from the Pancreatic Cancer Casebook. I have to tell you, this is one of my most favorite educational activities I do because of that connection with Let's Win. There's nothing more tying to the heart and tying to the soul of why we are all here at ASCO, why we do what we do every day, why we're here learning about the latest and greatest innovation for the treatment of patients with pancreatic cancer, than seeing these videos and remembering why we're here. We're here for the patients, right? We're here to provide them with more celebrations, more time, more family get-togethers, more quality of life. And so I think as we go through the talks today, and we have a lot of data to show you, always keep in your mind why we're doing this and why it is so important that we dedicate our lives to doing this is for those patients that you see on this video, those patients you take care of every day, and those patients around the world that you affect with your research and your time. So thank you so much for that. I'm Johanna Bendel. I'm the chairwoman for tonight's talk. I'm from Sarah Cannon Research Institute in Nashville, Tennessee. I'm so honored to be joined by my co-panelists, Dr. Andrew Hedifar, Dr. George Kim, Dr. Michael Pishvin, and Dr. Rajesh Roth. What are we going to go through? We're going to do updates on neoadjuvant and adjuvant therapy, as well as treatment for locally advanced pancreatic cancer. What are we doing now for personalizing treatment for these patients with metastatic pancreatic cancer? What's the latest and greatest with the BRCA mutations, and looking at this targeted therapy approach for patients with pancreas cancer? What are we doing next to look at targeting the stroma and the immune microenvironment to help our patients? So to start us off tonight, I'm so honored to introduce Dr. Rajesh Roth. She's the chief of the section of GI Medical Oncology and associate professor of medicine, the leader of the GI disease-oriented team, chair of the Data Safety Monitoring Board, and she's at the University of Arizona Cancer Center in Tucson, and so pleased to have you here with us tonight. So
thank you.
Thank you.
So I am delighted to speak, and thank you for the invitation. And my topic will be discussing adjuvant and neoadjuvant therapies and the approach to locally advanced disease. I'm going to just start with giving us a little bit of context in terms of where we're at right now for adjuvant therapy. So these are the NCCN guidelines currently for the adjuvant approach to resected pancreatic cancer. So the preferred regimens that are currently listed are based on level 1 evidence, and those include gemcitabine and capecitabine, as well as modified FOLFIRINOX. There's a number of other recommendations that are listed, including gemcitabine, which is slightly older data, and 5-FU leucovorin, continuous infusion 5-FU, capecitabine, as well as induction chemotherapy. The NCCN guidelines and the ASCO guidelines are slightly different, but the NCCN guidelines basically say that chemotherapy alone or chemotherapy in addition to chemoradiotherapy can be used for adjuvant approaches. ASCO recommends postoperative radiotherapy and adjuvant gemcitabine-based chemotherapy for a total of 6 months. These obviously are needing to be updated with some of the data that I'm about to show. Some other things to consider in these patients. So these are patients who have undergone complete resection, and so most patients should have formal restaging in terms of CT imaging, as well as tumor markers with CA19-9 that are checked, and you'll see that that was some of the requirements for the PRODIGE FOLFIRINOX study. In terms of optimal timing, there's really no clear consensus. ASCO recommends starting adjuvant systemic therapy for 6 months within 8 weeks of surgery. That's assuming that there's adequate recovery. However, there is data that shows that even starting it within 12 weeks of surgery still demonstrates a recurrence-free survival benefit. So this is the first big study that really has come out in the adjuvant space in some time. This is the PRODIGE study that was presented at ASCO and has subsequently been published in the New England Journal. These are patients who underwent R0 or R1 resection, so a complete resection or a microscopically positive resection margin, and underwent postoperative CT imaging. Importantly, these patients had to have a CA19-9 level of less than 180 within 12 weeks after surgery, and a total of just under 500 patients were randomized. I point that out because none of the prior adjuvant therapy studies had really required a CA19-9 that be below a certain cutoff level. So the thought is that a lot of patients who may have had microscopic metastatic disease that had not presented itself yet may have been excluded from this study. This was a study comparing FOLFIRINOX to gemcitabine, and what I think is really the dramatic thing that was noted here was the overall survival in terms of the FOLFIRINOX arm. We hit 54.4 months, and just to remind you, to put it in context, the prior adjuvant studies had median overall survivals in the 20 to 25 month range. So this was really dramatic. I'd also like to point out, however, that the gemcitabine arm did better than we have historically seen it do. So 34 months was the median overall survival. But because this was a statistically significant improvement, this has now been added to the NCCN guidelines. The APAC study is data that we are eagerly awaiting. So the concept of what works in the metastatic setting, let's try it in the adjuvant setting. FOLFIRINOX worked, and so gemcitabine and nab-paclitaxel has also now been tested. Again, patients underwent R0 or R1 resections. There was no CA19-9 cutoff here, and patients were randomized to gemcitabine versus gemcitabine and nab-paclitaxel. All we know so far is what's listed here. So the disease-free survival endpoint was 16.6 months for the treatment arm, and the control arm was 13.7 months. That did not meet statistical significance. The overall survival seems to show perhaps a slight benefit, but that that is not really understood in terms of context yet, and we know that these patients, once they recur, are getting subsequent lines of therapy. So in terms of neoadjuvant therapy, the NCCN guidelines say that there's limited evidence to recommend a very specific neoadjuvant regimen outside of a clinical trial. They also do recommend that these should be given with consultation and coordination at a high-volume center, and of course, encouraging participation in clinical trials. The preferred neoadjuvant regimens that are listed within the NCCN guidelines include the gemcitabine, nab-paclitaxel, and FOLFIRINOX regimens, and then plus or minus is how it's listed right now for chemoradiation. There is a caveat in terms of patients who have known BRCA1, BRCA2, or PALB2 mutations to consider platinum-based chemotherapy regimens, and we're going to hear a lot more about BRCA, but obviously platinum is the suggestion there, again, put into the NCCN guidelines, and as we know, they're now recommending germline testing on all patients, and so hopefully we would know what the BRCA status is on patients. In this space, there's actually a lot of activity going on. The PREOPANC study was presented last year at ASCO and was looking at neoadjuvant versus adjuvant therapy. These are patients who had resectable or borderline resectable pancreatic cancer, and it was about 246 patients. Patients were randomized to receiving gemcitabine, followed by radiation, followed by surgery, and then adjuvant gemcitabine, versus straight upfront surgery and then gemcitabine alone. The R0 resection rate seemed to be noticeably improved at 65% in the patients who received preoperative therapy versus those who went straight to surgery. The primary endpoint was median overall survival, which was 17.1 months in the treatment arm versus 13.5 months. A lot of the criticism of this study was, not a lot of us are using gemcitabine alone anymore, and that gemcitabine with radiation, the question of the role of radiation in the neoadjuvant as well as adjuvant setting is still up for debate. So those are some of the critiques of the study, but it does suggest a benefit to neoadjuvant therapy. The JSAP-05 study was also presented at GI ASCO earlier, and now there's some updated data out at ASCO this year. This was patients, again, who had R0, R1, potentially resectable disease, who received neoadjuvant chemotherapy with the preferred Japanese regimen of gemcitabine and S1, followed by surgery and adjuvant S1, versus upfront surgery. And again, median overall survival was 36.7 months versus 26.7 months, suggesting a benefit to neoadjuvant therapy. The NeoNAC study is neoadjuvant plus adjuvant therapy in patients. This is a phase 2 study who received basically perioperative therapy. They had 2 cycles of chemo, followed by surgery, followed by adjuvant chemotherapy, versus upfront surgery and 6 cycles of the combination of gemcitabine and nab-paclitaxel. So we don't really have any outcome data yet. The primary endpoint is disease-free survival, but all of us, I'm sure, will be watching this with great interest. The other ongoing study that I think will hopefully add a little bit of clarity to the neoadjuvant question is the SWOG ongoing phase 2 study, SWOG 1505, which is preoperative FOLFIRINOX versus gemcitabine and nab-paclitaxel. So these are patients who have resectable disease only, and they're randomized to receiving perioperative FOLFIRINOX versus perioperative gemcitabine and nab-paclitaxel. The primary endpoint here is 2-year overall survival, and so far what we know is that out of 103 patients, 96% have started and 83% have completed preoperative chemotherapy, and 77% of patients went to surgery, with 73% undergoing resection. There's been 1 death due to sepsis, and 61 additional patients have had grade 3-4 toxicities. So the poster that is presented basically is suggesting that preoperative chemotherapy is safety, and so far the ability to go to resection, those rates are encouraging, and that the study was feasible. That being said, they comment that some of these patients, once they got subsequent radiographic evaluation, central radiographic evaluation, the clear notion of resectability was kind of called into question a couple times, suggesting a really important quality control that needs to go in for these patients who have quote-unquote resectable or borderline resectable disease. This is the Alliance study, which I think is kind of the last study that we're really waiting to see a readout on. This was a phase 2 study. These were patients with borderline resectable disease, and they were randomized to receiving 8 cycles of FOLFIRINOX, followed by surgery, followed by completing off adjuvant therapy with FOLFOX, versus having 7 cycles of FOLFIRINOX and stereotactic body radiation therapy, followed by 4 cycles of modified FOLFOX. The primary endpoint here is overall survival, but they were also looking at secondary endpoints, including R0 resection rate and event-free survival and path CR, as well as safety. What we know so far is that about 120 patients have been accrued, and it's basically completed accrual. They had an interim analysis that was planned for futility that was looking at R0 resection rate. And when they did that interim analysis, which ended up being with the majority of patients enrolled, it did actually meet its boundary for futility. And so the stereotactic body radiation therapy arm was dropped. What that really means, I don't think we know yet, but what we do know is that patients, the subsequent patients that went on the study all went on the chemotherapy alone arm. Moving on to locally advanced pancreatic cancer, we have a lot of new things going, but this study is kind of what formed the foundation for maybe why radiation-based studies started to fall out of favor a little bit. So this is the phase 3 LAP-07 data. These are patients who had locally advanced pancreatic cancer. 442 patients were enrolled, and they underwent a randomization first to receiving gemcitabine versus gemcitabine and erlotinib, which should show you how long ago this study was planned, followed by a second randomization. And these were patients who had not progressed and then were randomized to gemcitabine with radiation versus gemcitabine with erlotinib and radiation. And the median OS in the chemotherapy-only group after that first randomization was 16.5 months versus those who received radiation therapy, which was 15.2 months. So in these patients, the suggestion was that there was no survival benefit with the addition of radiation, and so people started to call into question the utility of radiation in locally advanced pancreatic cancer. That being said, subsequent readouts that included local progression and such were actually suggesting a benefit to radiation. So this is still an ongoing debate between the medical oncology and radiation oncology communities. Currently, the guideline recommendations for patients with good performance status, combination chemotherapy, whether that be FOLFIRINOX or gemcitabine and nab-paclitaxel, or in BRCA patients or PALB2 patients, some sort of platinum, and then more single-agent therapy in patients with poor performance status. Subsequent box on the NCCN guidelines says that depending on performance status, mono or combination systemic chemotherapy may be considered as initial therapy prior to radiation, and that can be chemoradiation or stereotactic body radiation therapy for appropriate patients. So there's still a role for radiation in the NCCN guidelines that is suggested. So in terms of the ongoing studies in the locally advanced or initially unresectable or borderline resectable patients, there was the NeoLAP study. And this is a study where patients received gemcitabine and nab-paclitaxel for 2 cycles, followed by continuing on this, versus switching from gemcitabine and nab-paclitaxel to to chemo-intensified FOLFIRINOX. The primary endpoint here was R0 resection rate. At least at the interim results, what they saw was disease control rate that was about similar in both arms. So again, similar percentages were taken for exploratory laparotomy. The R0 and R1 resection rates were again 24% in the 2-drug arm versus 29% in FOLFIRINOX, but that in patients who actually were able to undergo exploratory laparotomy, that both arms seemed to suggest a role for induction chemotherapy and promising secondary resection rates. There was no clarity really in terms of multi-agent chemotherapy, whether there should be 1 versus the other, 2 versus 3. And so based on this, a lot of the authors' conclusions included that performance status and toxicity and all of those other things should continue to go into our discussion about what to offer these patients in the preoperative or neoadjuvant space. The LAPACT study was a study of, again, locally advanced patients. They received induction with nab-paclitaxel and gemcitabine, and then were able to actually continue on with investigator choice. So they could continue with the gemcitabine nab-paclitaxel. Alternatively, they could move on to radiation, or if they were converted to a surgically resectable tumor, could go to surgery. The primary endpoint here was TTF, and of 107 patients enrolled, 45 patients received the induction chemotherapy. 12 of those went on to continue receiving the chemotherapy. 17 moved on to chemoradiation, and 16 underwent surgical resection. So this was the median time to treatment failure, which was 8.6 months, and a median PFS of 10.2 months. And there was a suggestion that this was very promising data. And the disease control rate was 78% with an overall response rate, as we would typically expect with gemcitabine and nab-paclitaxel, about 35%. The only caveat to some of this is that the study was actually designed and powered in terms of the statistical basis for this was based on the metastatic data. So a lot of the historical controls that they were using to make their null hypothesis and their endpoints was based on the impact study on the metastatic pancreatic cancer population, which we know is really a different beast in terms of the time to treatment failure, progression-free survival, and other efficacy endpoints. In terms of the most common grade 3 treatment adverse events, primarily things that we would expect with this chemotherapy: neutropenia, anemia, and fatigue. So moving on into the more exciting space, which is the newer studies that are ongoing in the locally advanced pancreatic cancer world. We do have the data that was presented at ASCO a few years back, which was the phase 1/2 study of pamrevlumab with gemcitabine and nab-paclitaxel. Pamrevlumab inhibits the connective tissue growth factor receptor and is a targeted therapy that is thought to play a role in kind of stroma modulation, which we also know nab-paclitaxel perhaps could work synergistically with. So this was a study with patients with locally advanced pancreatic cancer that were randomized to receiving gemcitabine and nab-paclitaxel versus the pamrevlumab in addition, and then were taken to surgery if feasible. The median PFS of the combination arm was 18.4 months versus gemcitabine and nab-paclitaxel of 10.1 months, and at the time of presentation, the median OS was not met. So based on this, there is a phase 3 study going on right now, or that has at least been registered and is going to be starting to accrue, of pamrevlumab in combination with gemcitabine and nab-paclitaxel. Tumor treating fields is another really kind of exciting and novel concept in terms of treatment modalities for this disease. So what we know about this approach to therapy is that living cells are polar, and they have charged molecules. And these charged particles and dipoles can be influenced by alternating electric fields. So tumor treating fields are alternating low-intensity electric fields that basically disrupt charged particles that are present during mitosis. So what that leads to is cell death in rapidly or actively dividing cancer cells. And so what you see here is exactly that. You see this disruption of the alignment of the polarized tubulin subunits, which basically interrupts microtubule spindle formation during mitosis and can lead to apoptosis. This approach in terms of therapies is already FDA approved in glioblastoma and has also been looked at in a number of other diseases. This is a portable, non-invasive device that basically attaches, as you can see in the picture, to the patient's body right where the tumor is. So for glioblastoma, it attaches to the scalp. In pancreatic cancer, it basically attaches to the abdominal trunk. Alternating electric fields are delivered using 4 different transducer arrays, and it's basically portable and operated by a battery. So there was preclinical data that suggested that TTF with gemcitabine demonstrated increased efficacy in reducing tumor volume. And so based on that, the PANOVA-2 study was designed. So this was in patients with advanced pancreatic cancer that included locally advanced as well as metastatic, actually. And in those 40 patients were randomized to receiving TTF with gemcitabine versus that with nab-paclitaxel and gemcitabine. And as you can see in the locally advanced patient in the intention to treat population, the median PFS was 12.7 months with a median OS that had not been reached. Importantly, the combination was also safe and tolerable, and there was a feasibility to this study that they looked at, and it was a very feasible treatment modality in terms of making sure that these patients were compliant with having this device attached to them and such. So now we have the PANOVA-3 that is an ongoing study. This is newly diagnosed locally advanced pancreatic cancer receiving standard of care gemcitabine and nab-paclitaxel versus tumor treating fields with the 2-drug chemotherapy combination. The other area of interest is really intra-arterial gemcitabine. So this is a catheter system that basically isolates the anatomy and microperfuses targeted tissue with gemcitabine. So it's direct targeted via the artery into the pancreatic tumor. Patients with stage 3 pancreatic cancer, 20 patients were initially looked at. And in those patients, there was 7% partial response, but stable disease was 73%, with a reduction in CA19-9 in 60%. This was the survival data. And so based on that, we have the TIGeR-PaC study. The TIGeR-PaC study is a phase 3 study looking at induction therapy with IV gemcitabine and nab-paclitaxel with radiation, and then patients are randomized to receive the intra-arterial therapy versus continuing with IV chemotherapy. And then lastly, we just wanted to highlight some of the ASCO 2019 abstracts of interest, as there is a lot of other things that are ongoing, including looking at neoadjuvant FOLFIRINOX versus adjuvant gemcitabine, the JASPAC-05 study, which is a phase 2 trial of neoadjuvant S1 and concurrent radiation in borderline resectable pancreas cancer, and PRIMUS-002, which is a phase 2 study looking at FOLFOX and nab-paclitaxel and gemcitabine as neoadjuvant therapy for borderline resectable pancreas cancer, and also kind of looking at biomarkers and liquid biopsies in the process of that study. Take-home conclusions are listed here. For resectable disease, PRIOPANC and JSAP-05 support the use of neoadjuvant treatments, and we're really awaiting the results of SWOG 1505 and the Alliance trials. And then in the locally advanced space, LAP-07 showed no overall survival benefit to radiation. LAPAC showed induction with gemcitabine and nab-paclitaxel is effective, but it was a single-arm study, and the stats were powered to the metastatic historical controls. And we have a lot of novel therapies with exciting studies ongoing that we're awaiting results on. Thank you very much.
Thank you for such an amazing, comprehensive talk. I mean, who would have thought that we were talking about increasing the cure rate of patients with adjuvant therapy for pancreatic cancer? One of the questions that's come up is talking about the difference in the regimens that were used for the adjuvant treatment, modified FOLFIRINOX versus FOLFIRINOX, and the reasoning behind using the modified FOLFIRINOX in the adjuvant setting.
Yeah, so, I think from the initial metastatic study to the evolution of the PRODIGE adjuvant study, modified FOLFIRINOX, there's been so many different retrospective studies that have looked at using the modified regimen, which is basically no bolus 5-FU leucovorin. And in those retrospective data and such, there's been kind of a generalized acceptance that this is a safe and tolerable and still reasonably effective regimen. And so as a result, when the PRODIGE study was first designed, they planned to use the modified regimen. The data speaks for itself in the terms of it's clearly an effective regimen. And I think, frankly, if you looked at some of the safety data from the adjuvant setting, I mean, in these post-operative patients especially, they actually did reasonably well.
Yeah. Very much so.
Yeah.
And one other quick question that came up, we're looking at all of these localized therapies, including the SBRT. Do we use radiation? Do we not use radiation? Very controversial. Are there other localized therapies like thermoablation or things like that that are being looked at or think you might have a role here?
Yeah, there's a lot of interest in things like thermal ablation. There's IRE, so irreversible reverse electroporation. There's a lot of things that are looking at those studies. The problem is, for instance, in IRE, all the data is really kind of either single institution or retrospective, and so we don't have prospective evaluation of those studies. I mean, should they be done? Absolutely. Are they going to be done? I don't know, frankly, because it's hard. Those are very specialized techniques, and the expertise needs to be there, and so it has to be at high volume centers with people that are trained to do those things.
Excellent. Thank you so much. And we're going to talk about a case. So thinking about standard therapy and clinical trial options in locally advanced pancreatic cancer, and I think one of the things that you'll hear a theme resounding through tonight's talk, you heard this also with the Let's Win video, is the importance of participation in clinical trials, because this is the only way that we're going to change the outcome of this disease. So this is Susan, a 65-year-old woman diagnosed with unresectable locally advanced pancreatic cancer, ECOG PS of 1, adequate liver function, and we'll talk about this a little bit later. What testing do you do now? Now that we have some answers from molecular profiling for patients with pancreas cancer, looking at MMR, looking at BRCA, looking at PALB2, she's eager to pursue aggressive therapy, but is also open to clinical trial enrollment. And so looking at her standard therapy based on her good performance status, she's a great candidate for chemotherapy, and certainly we have NCCN guidelines that talk about some of the recommended potential treatments with Gem/Nab-Paclitaxel and FOLFIRINOX, just like we heard from Dr. Schroff, plus or minus radiation therapy, and reserving the single-agent chemotherapy for patients with a poor performance status. So really the take-home message from Susan's case is just to remember for those locally advanced non-resectable patients to look at those chemotherapy options, plus or minus radiation therapy, but even more to always keep in mind the possibility of a clinical trial. So she was considered actually for the couple of clinical trials, the PANOVA-3 study, the tumor treatment fields with nab-paclitaxel and gemcitabine. And really interestingly, not only for glioblastoma, now get approval for mesothelioma for the tumor treatment field. So really something potentially to this possible treatment. So very excited to try to enroll patients onto the PANOVA-3 study. And then the TIGER-PAC study of the intra-arterial gemcitabine, another very novel approach to trying to deliver the drug better to these tumors to have a better anti-tumor effect. And with that, we'll talk about more personalizing chemotherapy sequencing with Dr. George Kim.
Thank you to Peerview Medical Learning and obviously Les Garten. That's a great video, Allison. That was great. Let's Win. And a lot of those testimonies have to do with what I'm going to talk about tonight, because you're right. We don't cure all our metastatic patients, but we do extend time. And we do get them to important anniversaries, holidays, birth of grandchildren, very important events. So let's go through the data. I'm going to talk about treatment of metastatic pancreatic cancer, evidence of personalizing chemotherapy sequencing in metastatic pancreatic cancer. So these are the approved treatments for pancreatic cancer. Just to remind everybody, gemcitabine was our standard for many years. We don't talk about this anymore. Then came FOLFIRINOX, and then nab-paclitaxel, gemcitabine. These are our two standards. And then nanoliposomal irinotecan, okay? What you don't see here is FOLFIRI, and you don't see FOLFOX. Those are not considered standards, and we'll go through some of that data. So the first trial we need to talk about is the ACCORD trial. This is FOLFIRINOX versus gemcitabine. This is a French study. Patients had to have metastatic disease. There was age limitation. The patients were selected in terms of performance status, ECOG 0 and 1. Relatively small study, 342 patients. Overall survival was a primary endpoint. Randomization was to gemcitabine or FOLFIRINOX, and the FOLFIRINOX was the kitchen sink approach of all the GI cancer drugs, with oxaliate 85, irinotecan at 180, and the bolus 5-FU. And what this showed was that there was an overall survival benefit, 11.1 months, versus gemcitabine of 6.8 months. So clearly, FOLFIRINOX showed superiority versus gemcitabine, and this is how this became a standard regimen. But it was at the cost of toxicity. The toxicity was, as you would expect, neutropenia, 46%, which led to about 43% of patients receiving growth factors, and I'll tell you why in a minute, why that's important. Thrombocytopenia was about a 9%. And then in terms of nausea, vomiting, diarrhea, these are very important side effects, especially when they're in combination. And then sensory neuropathy, we talked about 9%. So you have to watch out for the cumulative neuropathy that occurs with oxaliplatin, and also the thrombocytopenia. And that's important when you start talking about sequencing, which we hadn't talked about in pancreatic cancer for a long time, but we are able to talk about sequencing. How do we use our available agents to prolong time? Next, we have the MPACT trial. So the MPACT trial looked at gemcitabine with or without nab-paclitaxel. Again, a randomized phase 3 study, treatment-naive metastatic disease. Patients had to have KPS of 100, 90, 80, or greater than 70. So what does that mean? It means your patients with ECOG 0, 1, and 2 were included. There was no age limitation here. The trial was a global study. It was done throughout the globe. Most of the patients were enrolled in the U.S. Most of the patients were in the U.S. in the community setting. Primary endpoint was overall survival. These are the arms, gemcitabine versus nab-paclitaxel, gemcitabine. And again, I just want to remind everybody, this was the regimen used, the 125 milligram per meter squared dose, given weekly 3 out of 4, and then the control arm. With this, the overall survival was 8.5 months versus 6.7, hazard ratio 0.72, statistically significant. So clearly here, again, regimen is superior to gemcitabine. In terms of toxicity, we also see neutropenia, this time 38%, less use of growth factors, thrombocytopenia roughly 13%. And then in terms of peripheral neuropathy, you do see peripheral neuropathy right around 17% in the grade 3 level, diarrhea. And importantly, this peripheral neuropathy is reversible, unlike the oxaliplatin. In terms of median onset, it's roughly 140 days, roughly 4.5 months. Improves if you hold the nab-paclitaxel for about a month, and about 44% of patients can restart the agent. So this is important when you compare and when you're trying to sequence patients. The neuropathy with nab-paclitaxel is reversible. It can go away, and then you can think about other treatments, and I'll show you that in a minute. So this is a slide comparing the trials. I've already talked to you about the FOLFIRINOX French trial versus the MPACT GEM nab-paclitaxel trial, mainly in the US, really kind of real-time patients. Selection performance status 0-1, again, KPS 70 to 100, so ECOG 2s. Survival 11.1 versus 8.5, but if you kind of compared apples to apples, in the good performance status patients, the survival was as good as 12.6 months. 1-year survival, objective response rates. In the FOLFIRINOX trial, they let the investigators assess the CTs. In the MPACT trial, they had it centrally reviewed. Their response rate was 23. If you let the investigators assess the scans, it was 29. So they were similar in terms of response rate, and you're going to hear more about why that's important. Fatigue, neutropenia, and then neuropathy. Again, this neuropathy tends to be challenging to reverse, whereas this neuropathy is reversible. Poor performance status patients probably are not going to tolerate FOLFIRINOX, and again, you can treat your poor performance ECOG 2 patients with the GEM nab-paclitaxel regimen. Database looking at inpatient, outpatient claims, hospital-based, both community and academic, mainly in the Southeast, showing the costs, monthly cost between nab-paclitaxel GEM and FOLFIRINOX, and believe it or not, nab-paclitaxel GEM is lower in this analysis. Obviously, the acquisition costs are higher, but when you start factoring the growth factors and then the hospitalization, FOLFIRINOX, despite the drugs being generic, does start to add up. So very important, and there are plenty of analyses. This was about 300, 400 patients, so pretty good data. So what are we doing now? So this was presented at GI Asco. This is Pan-Optimox, a French study. You know how we Optimox in colorectal. This is a very similar approach. Arm A was FOLFIRINOX. Patients receive treatment without interruption. Arm B was patients received treatment for about 8 treatments or 4 months, and then they went on to maintenance therapy. You're going to see this in the Polo presentation, this very approach. This is now becoming a very interesting way to do trials, looking at agents that can cause disease stabilization. Nonetheless, this was the trial, and what they show in overall survival, 10 months versus 11 months. So you don't lose much by removing the oxaliplatin at that 4-month point. Metastatic disease, good performance status patients, these are the NCCN guidelines. Clinical trials, we still have a lot of work to do. Preferred is FOLFIRINOX, can be modified, and then gemcitabine nab-paclitaxel also available for the patients with poor performance status. And Dr. Schroff has already talked about the BRCA patients and the use of cisplatin and also FOLFIRINOX platinum. Poor performance status, gemcitabine I still use as standard infusion. Some people use the fixed dose rate. Capecitabine, continuous infusion 5-FU. So let's move on to second-line therapy. So category 1, and there's only one category 1 on this slide. It is Nal-IRI plus 5-FU leucovorin. ASCO recommends in patients with good performance status. Other regimens are listed here. They're 2A, FOLFIRI, modified FOLFIRINOX, oxaliplatin-based regimens, capecitabine, continuous infusion, 5-FU. I just want to highlight down here, they're rare, but they're out there. Pembrolizumab can be given to patients with MSI high, defective mismatch, and also the NTRK gene fusion drugs are available. So we have to remember that, all right? And then if the patient had prior fluoropyrimidine, They can try to go on gem-nab-paclitaxel. Again, the neuropathy story, we'll get into that in a minute, but also other treatments available. So second line, we thought that oxaliplatin would be the standard. This is the German off regimen. It did show a survival advantage, 6 months versus 3.3. And then the Canadians got a hold of the drug, and they tested Folfox, and they showed that actually 5-FU was better than Folfox. And so that's why we don't necessarily think that oxaliplatin is the standard in second line. Well, what about Naliri? Okay, what is Naliri? 80,000 molecules in a liposome. Half-life is prolonged. Drug stays around the patient's body for a week. Higher doses of SN38 in the tumor, because remember, regular naked irinotecan probably just goes right by the tumor, as opposed to these agents that deposit near the tumor, get to the cancer cells, and then kill them. So very important. We're going to hear about the stroma in a few minutes. So this is probably how liposomal irinotecan is able to kill cancer cells, as well as nab-paclitaxel, again, affecting the stroma and getting to the cancer cells. So this is the trial. This is the Naliri Napoli study. The trial was Naliri combined with 5-FU leucovorin versus a control arm of 5-FU leucovorin. There was this Naliri monotherapy. You have to remember patients had to have prior gemcitabine and ethnicity. This was important because the drug was developed in Taiwan. So 30% of the population came from Asia, Taiwan and South Korea. And that's important when you look at some of the neutropenia data. And also when you try to compare this to some studies that are being done in the US. So very important. Primary endpoint in this study was overall survival. Just to remind people, patients had to have had gemcitabine in the past. So some of the patients had gemcitabine in the adjuvant or local advanced setting, roughly 13%. Then they developed metastatic disease, and so they were considered eligible for the trial. Most of the patients, 53%, had one prior gemcitabine-based regimen, so they truly were gemcitabine refractory or in the second line, and then greater than 2. Most of the patients received gemcitabine combination, either with a fluoropyrimidine, irinotecan, or platinum. Only 10% had prior irinotecan. These are the data in terms of overall survival, 6 months versus 4.2 months. Important in the second line, if you remember most GI cancer trials in the second line, the delta is about 2 months. So this is in line with that. So it ended up being approved for gemcitabine-based or post-gemcitabine. Diarrhea, 13%, nausea, vomiting, neutropenia, 27%. Again, most of those patients were the Asian population. So what we're seeing more and more, and I think we saw this with the regorafenib trial, the REDOS trial in colorectal, is if we make dose reductions, we're not harming patients. We're actually maybe helping them, keeping them on drug longer. So what these show is in the Napoli-1 trial, if you had a dose reduction or dose delay, you do not lose anything in terms of outcome. Here in this analysis, a dose reduction leads to a survival of 9.4 months, and then if a delay, you get about an 8-month. So you're really not harming patients. The point here is that you're trying to ease the patients into the treatment and allow them to stay on therapy that is active for a longer period of time. And that's also true with nab-paclitaxel, where again, dose reductions led to survival of about 11.4 months, and then dose delays led to 10.1, okay? So again, getting into this theme of, remember this is palliative therapy. We want to give the patients the best treatment, but we also want to make sure they stay on treatment. So where are we now in 2019? We have 2 treatment options, the gem-based treatment, gem-nab-paclitaxel, versus a 5-FU-based treatment, FOLFIRINOX. If we go the gem-based approach, we have the paclitaxel, the neuropathy that occurs, the thrombocytopenia, but again, it's reversible. And we can go on to a 5-FU-based regimen, Naliri, okay? Naliri, 5-FU leucovorin. This allows the patient's nerves to rest. There is no neuropathy associated with this regimen, and also allows the bone marrow to rest. And then we can go on to other treatments. If we select this approach, we're thinking more and more about maintenance. But we do run into the neuropathy issue when we try to go from oxaliplatin and nab-paclitaxel, and also the thrombocytopenia issue. So I think more and more we're going this route, but again, you have to sit with the patient, ask them what they want to do. Do they want maybe some maintenance, or do they want all the available treatments to prolong time? So with that, I think I will stop.
So this is looking at sequencing, going over some of the concepts that George just talked about. We're talking about David, 66-year-old gentleman diagnosed with metastatic pancreatic cancer, history of diabetes and depression. Diagnosis was based on the CT scan showing a large mass in the head of the pancreas, ECOG performance status of 1, liver and local lymph node mets were identified, and he talks with his oncologist about treatment with available platforms and does initiate treatment with gemcitabine and nab-paclitaxel, talking with the patient about preferences, thoughts in terms of how to sequence the treatment that the patient's going to get, talking a lot about the side effect profile, which seems to be very important for patients, looking at gem nab-paclitaxel versus FOLFIRINOX. And then I think one of the questions that came up, and George, I'm going to throw this your way, is talking about the growth factor support. So we did see growth factor support being given in the IMPACT study. We do use growth factor support when we give FOLFIRINOX and maybe even modified FOLFIRINOX. What's your approach to that, and how do you handle it?
Yeah, I'm old-fashioned. I let the patients express themselves, meaning if they do become critically neutropenic, then I'll initiate it. I don't empirically start them on, because then you're committing them throughout the treatments.
Now, in the IMPACT study, they actually used daily dosing of GCSF rather than a long-lasting dosing. When you modify your gem nab-paclitaxel regimen, if you've got a patient that becomes neutropenic, do you have a preference? Do you do the daily GCSF dosing, or do you switch to an every other week dosing of gem nab?
Yeah, great point. I mean, GI oncologists don't know how to give GCSF. We're not used to doing that. So yes, but if you do use that every 2-week Ohio State regimen, you don't need as much growth factors. So that's one of the advantages of that regimen. Yeah.
And so, and thinking about metastatic pancreatic cancer and thinking about treatment and trials, we're about to hear a talk from Dr. Pishvan about looking at targeted therapies and molecular profiling. And just as a hint, so when you see a patient with a new diagnosis of metastatic pancreatic cancer, what do you like to look for?
I definitely like to initiate germline testing because it's something that should be standard for all patients now. And then I do like to initiate a somatic tumor profile that actually gets a pretty broad set of genes tested and includes some form of testing for microsatellite instability or mismatch repair deficiency.
Excellent. And then moving on to the next line, the second step in the sequence. So he gets gem nab, got response and controlled disease symptoms, but then progressed. And then it started on Nal-Iri with 5-FU. And so talking a little bit about the toxicity profile for this combination, George, you mentioned it, thinking about the diarrhea. So we do know that these regimens can cause diarrhea. What is your approach, though, to the patient with pancreatic cancer who's having diarrhea? Other things that could cause it, other things that you might want to think about when trying to implement a treatment regimen?
Absolutely. So you have to be very careful of pancreas insufficiency. So you may think about replacing their pancreas enzymes, which are affected, obviously. So have them take the enzymes with food, up to 2 or 3. Make sure the stools, we talk a lot about stool and GI oncology. Make sure the stools are formed, not particularly flatulent, malodorous, oil and water, very important, and make sure they're not losing a lot of weight. So you do have to ensure that. And then if they got antibiotics recently, get them back on the right flora, all of those things. So
you have to think about C. diff too.
Yep, of course.
Yeah. So just things to think about when we think about symptom control for those patients with pancreatic cancer in our treatment.
Thank you. And thank you for peer review for inviting me to give this talk. I'm really excited. This is actually an area that I'm very, very passionate about. And I don't want to also forget to give a shout out to Allison Ocean and Let's Win PC. They've really done a remarkable job in just a few years, and they should know that they're very positively impacting patients. So I'm going to talk a little bit about empiric therapy and then about targeted therapy and then go into a discussion about the DNA damage repair pathway. But starting to sort of set the context and talking about standard of care, we've had two really great talks about well-done studies that have established the standard of care for pancreatic cancer. But the reality is that when we do standard of care trials, we're really talking about empiric therapy, and we're talking about learning how to treat a group of patients, but in reality, only about 30% of patients, for example, with the FOLFIRINOX data that was just shown, will benefit from therapies, and all the patients will get the treatment, but we really don't know who those 3 are or who that 30% are that will ultimately benefit. And this is exemplified here. We saw the survival curves, but unfortunately 70% of patients who got FOLFIRINOX don't actually have their tumor shrink. There were about 30% that were stabilized, but only about 30% whose tumors frankly shrank. And most of these patients will ultimately succumb to their disease. So the promise of personalized, or otherwise called precision medicine, is really the ability to use specific predictive biomarkers to identify a priori which patients will benefit from specific therapies. And there's two different ways in which I think of precision medicine. First of all, we're doing molecular testing not for a diagnostic purpose, but actually for a therapeutic purpose. And what we're looking for is in any individual patient, distinct, targetable molecular abnormalities that could be a predictor of response to therapy. These are the so-called actionable biomarkers. And there's so much that phrase actionable is thrown around so much that we actually really have to define what actionability means as well. And what we've defined actionability as is where there's literature that supports a high response rate or a high degree of benefit with that in patients with that molecular abnormality who receive that specific targeted therapy. Now, I have to add for a pancreatic cancer talk that that's in any cancer type, because really to date, we still don't have any targeted therapy specific for a predictive biomarker in pancreatic cancer. The other sort of softer category is that there may be possible implications of response to therapy based on the underlying mechanism, but perhaps it hasn't been proven out in clinical trials yet. So that's sort of the foundation for how we're going to go through this talk in terms of actionability. And it's important to recognize, because there's a lot of cynicism out there in the world, it's important to recognize that there are actionable findings in pancreatic cancer. There's been about 8 very large publications. I was trying to do the math in my head recently. I think it represents about 3,000 separate individual patients that have been tested, and they've all shown pretty much consistently the same thing, that about 25% of patients with pancreatic cancer harbor actionable findings in their tumor or in their germline testing as well. And you see some of the ones highlighted here. We're going to talk a lot about the DNA damage repair pathway, but there's a number of other ones as well that can pop up in a patient's pancreatic cancer. They may be rare, but we see them and they can impact patients. So a couple of specific examples of the rare mutations. One certainly is MSI-high findings in patients with pancreatic cancer. This is a really small subset of patients. It's definitely worth looking for, but I think at most it's about 2%, probably more like 0.5% to 1% of patients. But there definitely have been responses, frank responses, tumor shrinkage to immune checkpoint inhibitors for this patient population. Young Lee's data set from the Science paper actually told us that there were 6 patients who received pembrolizumab. Actually, all of them had their tumor shrink a little bit. 4 of them achieved a true RECIST criteria response. There's also another important subgroup of patients, the so-called KRAS wild-type pancreatic cancer patients. This is a real population. It represents probably more like 5%. The 10% is probably a little bit of an overestimation. And in this population of patients, in these tumors, there is not the KRAS constitutively active mutation driving the cancer cell, and so there are other drivers that are driving the cancer cell, and so these could be potentially targetable. Things like BRAF mutations, other receptor tyrosine kinase fusions. And for example, the data set put together by Dr. Singhi, they had 47 KRAS wild-type patients, and they found fusions in FGFR, RAF, ALK, MET, others. And these were targetable and actually did potentially benefit patients when they were identified. So I'm going to give you a specific example about the BRAF mutated patient population. Actually, Dr. Hendefar is leading this effort for us in the Know Your Tumor effort. And there were 18 BRAF mutations identified, 5 of which were the classic V600E, but there were others, there were 13 other mutations as well. And these patients, when appropriately targeted, can sometimes benefit from non-standard therapy. So one example that was presented at Asco GI is a patient who had a BRAF V600E mutation, and achieved a sustained partial response with BRAF-targeted therapy, with dabrafenib and trametinib. There are other similar case reports. So NTRK fusions have become really potent targets to be able to look for, because larotrectinib and entrectinib can really benefit patients whose tumors harbor these NTRK fusions. We were able to publish a data set of patients, 2 of whom had an NTRK fusion, 1 had a ROS fusion, all 3 of which were targetable by entrectinib, and these patients had prolonged benefit. And in fact, this patient had a very dramatic benefit, where you can see the time frame here where their PET activity went down just in 1 month, and actually the patient's symptoms improved also within 1 month. They were a patient that was virtually going to hospice, and within 1 month had recovered significantly. And to my knowledge, actually this patient is still alive and on entrectinib. There were ALK rearranged patients also seen, and Dr. Singhi also published one example of a patient with an ALK rearrangement treated with ceritinib, had a significant response to his disease when started on the ceritinib that lasted for well over 6, actually, or up to 12 months. So these kinds of findings are uncommon, but again, because you can see dramatic benefit in the patient population that has generally a poor prognosis and will be on chemotherapy, will not have sustained long-term responses, it is arguably worth looking for these findings. But the subgroup of patients that actually we think that are potentially going to be the most actionable and do the best long-term, and may really start to divide into an entirely different class of pancreatic cancer, the same way that EGFR mutated lung cancer is a different class of lung cancer, are those tumors who harbor these DNA damage response and repair mutations. It's a fairly complicated process. There's well over 80 enzymes that are involved in different aspects of DNA damage repair, from recognizing a single-stranded and double-stranded break through different proteins, allowing the double-stranded break to be repaired, inducing a cell cycle arrest so that there's time for the repair to take place, and also for alternative pathways like non-homologous end joining to be able to allow that repair to take place. And if there are defects in these different DNA repair pathways, there may be a way to exploit those defects with the appropriately targeted therapies. And these findings, these DNA damage repair mutations, definitely occur in pancreatic cancer. Again, about 17%, maybe up to 25% of pancreatic cancers harbor these DDR mutations. I present here a couple of different data sets. We had on your left the Know Your Tumor data set, which about 16.5% of patients had an DDR mutation. And from a larger CARES database review, there were about 17% of patients. And you can kind of see generally the list of genes that we're talking about. Certainly the classic ones are BRCA1, BRCA2, and PALB2, but actually probably the most commonly mutated DNA damage repair gene in pancreatic cancer is ATM. And then there's a whole long list of other genes in that DNA damage repair process that may be therapeutically actionable. But because BRCA is the one that's best established and most well-known, we'll talk a little bit about that specifically. So 5 to 7% of patients with pancreatic adenocarcinoma harbors germline BRCA1 or BRCA2 mutation, and the percentage can go up in specific populations. So for example, Ashkenazi Jewish patients have a higher predisposition to having germline BRCA mutations. It can be as much as 20% for Ashkenazi Jewish patients with a strong family history. Just having a family history of itself can double the potential for having a germline mutation. But I think that last bullet point is probably the one that I focus on the most, that of the patients who had an identified germline mutation in BRCA1 or BRCA2, when they went back and looked at the family history, actually up to 40% of patients who had a known germline mutation had no real discernible family history of breast, ovarian, prostate, or pancreatic cancer. And it's partly for that reason that in 2018, and certainly updated in 2019, that the NCCN recommended germline testing for all patients, 100%, all patients. I think you should hear that clearly. All patients with pancreatic cancer should have at least germline testing for an inherited mutation. So this gets into the mechanism of why this is relevant and why we have potentially targeted therapies that can actually harness these DNA damage repair deficiencies. The Parp inhibitors are the best example. There's approved Parp inhibitors on the market for breast and ovarian cancer, and so we're going to talk about the synthetic lethality that's seen with Parp inhibitor therapy in the context of a DNA damage repair mutation. What happens basically is that if chemotherapy, for example, damages a single strand of DNA, the Parp enzyme machinery can fairly rapidly initiate what needs to be done to repair that single-stranded break. If the PARP enzyme is blocked, for example, with a PARP inhibitor, then that will degenerate into a double-stranded break when there's replication fork arrest. But if the cell has an intact homologous recombination machinery, normal BRCA enzymes, for example, then the cell will quickly repair that double-stranded DNA break, and the cell will go on living. Synthetic lethality occurs when the PARP enzyme is blocked. There's double-stranded breaks that occur, but there is no underlying homologous recombination ability to repair that double-stranded break, and the cell will ultimately have developed so many double-stranded breaks that it will lead to mitotic catastrophe and cell death. This concept is being seen to be effective in patients with pancreatic cancer. And there's been a series of anecdotal cases. The numbers of patients are steadily growing. So walking through this just briefly. So one of the earliest data sets, one of the earliest anecdotes was back in 2015, where the Memorial Sloan Kettering group presented their patients who had received PARP inhibitor-based therapy and had an underlying BRCA mutation. 3 of the patients had a partial response with just the single-agent PARP inhibitor. The large BRCA-mutated cohort of patients across multiple disease types, led by the University of Pennsylvania, treated with olaparib, this again single-agent PARP inhibitor, had 23 pancreatic cancer patients, and there was a 22% objective response rate, including one patient who had a complete response to just single-agent PARP inhibitor therapy when they had an underlying germline BRCA1 or 2 mutation. Dr. Schroff recently published some really nice data with rucaparib that showed a 16% objective response rate, again, 1 CR with single-agent therapy and 2 PRs. And importantly, I think she did a real service to the community because she highlighted the fact that it wasn't just the germline BRCA-mutated patients that benefited, but there were also somatic BRCA-mutated patients, meaning they didn't have the germline mutation, but the mutation did exist in the tumor, that also benefited from rucaparib as well. There may be some synergy that occurs when combining a PARP inhibitor with chemotherapy. This is a phase 1b study led by Dr. O'Reilly, and they had a 78% response rate in BRCA-mutated patients with the combination of gemcitabine, cisplatin, and veliparib. Now, there are toxicity issues with some of the PARP inhibitors in combination with chemotherapy, so I wouldn't go run out there and add olaparib to any chemotherapy. But I think it definitely tells us that there may be a way to exploit the PARP inhibitor's ability to prevent DNA repair, along with chemotherapy causing more DNA damage. Another important piece of data that came out of Dr. Shaw's paper is she also highlighted the fact that patients who have platinum refractory disease are probably not going to benefit from PARP inhibitor-based therapy. And this is something that's becoming a relatively universal theme across disease types, breast cancer, ovarian cancer, and certainly now with pancreatic cancer. Of the patients who were treated with the rucaparib in her study, essentially none of the patients who had platinum refractory disease, meaning their disease had progressed while on platinum-based therapy, none of them benefited from PARP inhibitor-based therapy, with the exception of maybe one patient. It was the patients who had significant benefit were all either platinum naive or they had received prior platinum but had gone off of it mostly because of toxicity or just quality of life, and then were able to go on the PARP inhibitor therapy later. This is the phase 3 Polo study, the long-awaited results of olaparib as maintenance study in patients with germline mutated BRCA pancreatic cancer. The trial was a large international study, and it enrolled 154 patients for treatment, but it screened actually more than 3,000 patients, and patients were randomized to receive olaparib versus placebo with the primary endpoint of progression-free survival, and we do know from a press release in February that this was a positive study.
The primary endpoint, progression-free survival, was met with 7.4 months on the olaparib arm and 3.8 months on the placebo arm, equating to a 47% reduction in the risk of disease progression or death. The objective response was 23.1% in the olaparib arm versus 11.5% in the placebo arm at a median duration of response of over 2 years with olaparib. Beyond the improvement of progression-free survival, there were no new safety concerns with olaparib. Health-related quality of life was maintained with treatment.
We're all anticipating that this may lead to the first label indication of a PARP inhibitor in pancreatic cancer, hopefully soon. There are other really exciting studies going on using the same approach of PARP inhibitor-based therapy in the maintenance setting. These are both from Kim Rice-Binder up at UPenn. She has a maintenance rucaparib study that seems to be very promising. I have one patient on her study. It's doing great. But also, she's trying to harness the potential for Parp inhibitors to combine with immunotherapy in this same population. So we're excited to see what those results will show. There are also multiple abstracts that are at this ASCO meeting that highlight some of the benefits of Parp inhibitor-based therapy. Now, unfortunately, Parp inhibitors are unlikely to cure patients long-term. They may induce some long-term complete responses, but tumors will often ultimately become resistant to therapy. We actually published this one anecdotal case just because it was so remarkable and so illustrative of how patients can develop resistance to this, to Parp inhibitor-based therapy. This was a patient with a germline BRCA mutation, did remarkably well with a combination of FOLFOX and veliparib, had a near CR, but you can see that her tumor here in the pancreas, she also had liver lesions, but the tumor here in the pancreas virtually shrank away. We couldn't decide whether this was a true CR or not. But ultimately, over time, after 13 months on therapy, she had a little bit of regrowth and that grew into a real tumor. When we tested that recurrent tumor, she actually had the original BRCA mutation, but also a new deletion in the BRCA gene that actually caused the BRCA gene to reconnect and become functional once again. This is called a reversion mutation, and it does happen in pancreatic cancer, and it's one of the resistance mechanisms to Parp inhibitors and platinum-based therapies that we see. Parp inhibitors are definitely something that we're all focused on, but the reality is that this is a multi-pronged, very complicated process, and there may be other nodes to attack the homologous recombination DNA damage repair process that may provide additional therapeutic opportunities for patients. So, for example, there is definitely evidence of Parp inhibitors working for patients whose tumors have DNA damage repair mutations other than BRCA. There was a large data set in prostate cancer that showed several patients with non-BRCA mutated tumors that had other DNA damage repair mutations that responded to olaparib. There was some promising benefit of olaparib in an ATM deficient gastric cancer. The phase 3 study was negative, but actually was partly criticized for being an under-enriched population. More to see on that patient population. And then Talia Golan and Milan Javeli have the BRCAness phenotype study, and they have seen patients with other types of DNA damage repair mutations treated with olaparib that have benefited. So we should definitely be exploring the efficacy of Parp inhibitors in other DDR mutations. Flipping that around, we also should be looking beyond Parp inhibitors. So there are, again, multiple different angles to try and treat these cancers and these mutations, and there are other inhibitors that are out there. So, for example, one of the most exciting are these ATR inhibitors. The ATR inhibitors have been shown clinically in certain anecdotal cases to have benefit in BRCA-mutated patients. There was one highlight of a patient who had a BRCA-mutated tumor, had a PR with a Parp inhibitor, but then became resistant, and then had a PR with an ATR inhibitor. There also seems to be some real promise to combining an ATR inhibitor with chemotherapy in an ATM-deficient tumor type. And I mentioned earlier that ATM is actually the most common mutation when you look in pancreatic cancer. There are ways to try and suppress the ability or block the ability of the cell to slow down its cell cycle by inhibiting WEE1 so that you force the cell to go through the cell cycle and you don't allow time for DNA damage repair to occur. And again, non-homologous end joining is an escape pathway for repairing damaged DNA, and there are now some promising DNA PK inhibitors as well. This is really just meant to highlight that there are so many really well-designed, scientifically intelligent studies that are trying to maximize the DNA damage repair process and open up a therapeutic opportunity for patients with pancreatic cancer and other kinds of cancers. And if any or many of these studies become positive, we may have a battery of therapies to target this patient population for pancreatic cancer. So to summarize, I would really emphasize the idea that pancreatic cancers do harbor actionable mutations. In addition to the NCCN recommendations that all patients get germline testing, there was actually an addition in April this year in the NCCN guidelines that all advanced pancreatic cancer patients, which represents about 80% of pancreatic cancer patients, also should get somatic tumor testing to look for these rare mutations. The HR deficient, the DNA damage repair deficient subpopulation of pancreatic cancers are probably those with the greater promise. I do think that the outcomes are going to continue to grow disproportionately, and probably this will become its own subgroup of patients with pancreatic cancer. But there's also a lot of room for growth and understanding and questions that we don't yet know the answer to. Which BRCA mutations are the best? How to overcome resistance? What about beyond PARP inhibitors? What about beyond BRCA? And could immunotherapy actually make DNA damage repair targeting inhibitors even more effective? So I think this is a very exciting time for this population of patients.
So a lot of questions are coming up, right? There's, molecular profiling, is there a one-size-fits-all profiling panel? And I'm not sure that the answer is yes. So when we look at molecular profiling looking for mutations, are we actually catching the NTRK fusions, which we're probably not catching, but you think you might? We're talking about somatic mutations versus germline mutations. We're talking about BRCA mutations, but are they actually BRCA mutations that should be targeted? Are they, I hate to say actionable or not actionable, but are they relevant or not relevant? So what's your approach to trying to order the least amount of tests at once, and what are the things that you want to think about when you're looking for a profile to order?
So I'll try and take those one thing at a time. First of all, the fusions are the easiest to deal with because most NGS panels, unless they're specifically designed to look for it, don't capture fusions. A lot of times the fusion testing requires an RNA-based test, and so you should be using a panel that captures the kinds of fusions that we need to look for. NTRK fusions, BRAF fusions, other FGFR fusions, and so you want to make sure that the panel you're using has that. As far as trying to understand the panel to use, the reality is that these tests are done on chips that have dozens and now hundreds of genes on them, and really the chips are a commodity that are very inexpensive. And while we don't know that 600 is better than 300, we definitely know that there's probably on the order of at least 100 or 150 different mutations that may eventually become relevant, certainly up to 50 or more that are definitely relevant now. The lab you use, whether it's your own lab or whether it's a retail testing lab, you have to trust that they have the ability to call a pathogenic mutation, because most of us, including me, don't have the capacity to look at a gene mutation and decide on paper whether it's pathogenic. You have to trust that the computational biologists who are involved in the evaluation of that result actually know what's in the databases a true pathogenic mutation.
What do you think about liquid biopsies?
So liquid biopsies, we actually published a paper a couple of years ago claiming that liquid biopsies, while useful, were not sufficiently sensitive in pancreatic cancer. And I still think that's kind of true. Liquid biopsies are very useful when you find the mutation. So for lung cancers, when you have a very small, scant sample of tumor, and you just need to, you want to know if there's an EGFR mutation, well, if you test the blood and you find it, you're done, you're good. The specificity is very high. The risk is the sensitivity. So to do a liquid biopsy, if you find the mutation, it's useful, but if you don't, you may still need to go searching in the tumor.
Yeah. And one last question that came up, which I think is very interesting, is do you wait for your results before you start treatment for a patient?
That's why I think the maintenance setting is becoming very exciting, because as many of us have seen on this stage, patients are benefiting from chemotherapy for pancreatic cancer. I think that's one thing that the last 10 years have taught us, that thankfully it's technically the majority of patients that have some symptomatic benefit from chemotherapy for pancreatic cancer. And it buys you a window of time to be able to have the test results. And so to give a couple of cycles of chemotherapy, you're not likely burning any bridges. If you identify a BRCA mutation, now with the Polo data likely being positive, you're primed, you're set up to give them a few cycles of chemotherapy, 4 months of chemotherapy, and then move on to maintenance PARP inhibitor, for example.
Excellent, excellent. So really a change, almost a shift in our treatment paradigm for this group of patients. And you can see here, this is actually a patient from Let's Win. Doron, he was diagnosed with metastatic pancreatic cancer in fall of 2015, and then started on FOLFIRINOX, got mutational testing, just like we were talking about, ended up testing positive for a BRCA2 mutation, had neuropathy and hair loss while on the platinum-based treatment, but got a CR in 6 months. So that really shows the importance of using a platinum agent for those patients with the BRCA mutations. Then they actually switched because of the maintenance therapy for PARP inhibitors with Polo to using a maintenance therapy with olaparib for him. And then 6 months later, his MRI and CT scan showed no signs of cancer and still continues on olaparib therapy. So we see this where when you actually find the right thing to target and you have the right drug to target it, you can really make a huge difference in these patients' lives. I'm going to read the quote because, again, let's bring this back to the patients and why we're doing all of this. "I stopped working when I was diagnosed so I could concentrate on treatment. Now that I'm doing well, I'm back at work full speed. In 2017, I traveled to Europe and to Israel. I feel great. I'm healthy. I walk 12 miles a day, 6 days a week. My friends can't believe how well I am." So what an example of somebody living with cancer with the proper treatment. So really something to remember as we leave today. Finally, the next wave, what's coming? What's the hot stuff? Targeting the stroma in the immune microenvironment. Dr. Hedefar, thank you so much for joining us.
Yeah, thank you so much for the kind introduction. I wanted to thank PeerView and Lustgarten for co-hosting tonight's event. I'd also like to thank Dr. Allison Ocean for founding Let's Win, and my co-panelists for doing such a great job tonight. So I'm going to bring it home. My topic is going to be the next wave of innovation, targeting the stroma and the immune microenvironment. There have been several attempts at targeting pancreas cancer pathways, including therapies directed at the MAP kinase pathway, with the special recent resurgence in KRAS inhibition, therapies targeting PI3 AKT mTOR pathway, the Wnt beta-catenin pathway, and other pathways you see here. With the development of immuno-oncology, the tumor microenvironment has gained interest as a source of promising new therapeutics. In addition to cancer cells within the microenvironment, there are T cells, tumor-associated macrophages, cancer-associated fibroblasts, and finally, structural elements such as the stroma. PEGPH20 is an enzyme that degrades hyaluronan. It's a glycosaminoglycan which comprises a significant portion of the tumor stroma. In preclinical models, removing hyaluronan decreases intratumoral pressure, decompressing the vasculature, allowing chemotherapy to perfuse, which shows promising results. This promising early phase data as well has led to a large phase 2 trial in advanced pancreas cancer, where PEGPH20 was added to the standard regimen of gemcitabine and nab-paclitaxel. Here you see results from the HALO 202 study. The primary endpoint was progression-free survival, which was met in this cohort of approximately 230 patients with pancreatic cancer. The PFS went from 5.3 to 6 months with experimental therapy. Patients were segregated based on HA content, which was actually developed by a diagnostic companion biomarker, and HA high is defined as hyaluronan expression greater than 50% in the tumor stroma. As you can see here, based on this segregation, the progression-free survival benefit improved quite substantially. Secondary endpoints such as overall survival were reviewed. We should note that the study was empowered to evaluate these endpoints. In the overall cohort, there seemed to be similar overall survival benefit and perhaps a small but not significant benefit in the HA high subpopulation. These promising phase 2 data led to a randomized phase 3 trial in patients who have HA high tumors. Patients were randomized to PEGPH20 versus placebo in a 2-to-1 fashion. It was a difficult study, but it shows the interest of the pancreas cancer community that it was able to be done. So completed November 2018, and once 330 events are done, the final data should be reporting soon. Now, targeting the tumor microenvironment has a mixed history in PDAC. The recent reports of the phase 2/3 RESOLVE trial, which added ibrutinib to gemcitabine and nab-paclitaxel, were negative, unfortunately. Similarly, tirextumab, which is a Notch inhibitor, was also negative. SWOG 1313, in unselected patients, regardless of HA status, were given PEGPH20 and FOLFIRINOX. This was not a positive study. Now, there was data with nab-paclitaxel, which is a stemness blocker, which blocks STAT3 gene transcription. So what are the challenges to targeting tumor microenvironment? Well, it's immune suppressive. That's difficult. There's a lack of effector T cells. We talked about the dense fibrous stroma that exists, and as Dr. Pachvine mentioned, very low rate of MMR deficiency or microsatellite instability. Now, immune checkpoint inhibitors have really changed the way we treat cancer. They modulate T lymphocyte responses against cancer by blocking the negative regulation of immune responses. CTLA-4 antibodies allow co-stimulation of anti-tumor T cells, whereas PD-1 and PD-L1 inhibitors block the tamping of the immune system from PD-1 and PD-L1. Unfortunately, pancreas cancer has limited amount of effector T cells in the tumor microenvironment and also has a low mutation tumor burden, as demonstrated here. There's a lot of mature data sets, some of them done by the panelists here. At Memorial Sloan Kettering, 833 patients were sequenced, both somatic and germline, and MMR deficient pancreas cancer was only identified in 7 patients. And I think this is very interesting. All 7 patients had Lynch syndrome. So I would recommend anyone who does a somatic test or does a tumor testing and you find mismatch repair deficiency, please test for Lynch syndrome. It's probably very important that you do that. The group also reported 3,600 patients that they tested. 2,600 were evaluated for MSI and 1,000 for tumor mutation burden. MSI high or tumor mutation burden high were only detected in 0.5% of patients. And Dr. Pishvayan and his group have done a lot of work in the Know Your Tumor initiative, and they've tested a lot more than 386 patients, but this was just the published literature. Again, about 0.5 to 1% of patients are candidates for immune therapy. From the Memorial Sloan Kettering data, we see the difference in tumor mutation burden between MSS and MS-high pancreas cancer. The typical mutation burden for pancreas cancer patients is quite low, as you can see here. And only in patients who have microsatellite unstable disease do you have high tumor mutation burden. Dr. Pishvayan mentioned the study that I'm showing you, the waterfall plot here. Thankfully, immune therapy works for GI cancers, but we do have to select the appropriate patients. And patients with pancreas cancer who have MSI high or deficient mismatch repair, they do benefit significantly from these therapies. So we should be on the lookout for that. Now, in unselected patient populations, it's a little bit more difficult. Here, we see a group of patients that were given the CTLA-4 antibody and with one response. Interestingly, the response in this one patient mimics the response in other disease types where you see a transient progression followed by improvement. Similar work has been done with PD-L1 inhibitors. Here you see a cohort of patients treated with durvalumab. There were a few patients who were able to respond to therapy. Unclear exactly what the phenotype of those patients was. And this led to a very interesting phase 2 trial comparing PD-L1 inhibition versus PD-L1 and CTLA-4 in pancreas cancer. 60 patients were randomized in a 1-to-1 fashion. Unfortunately, there was no significant difference between the two groups, and when you compared their outcomes to historical controls, it didn't really warrant further testing. And I think that you'll see that there are almost no clinical trials using checkpoint inhibition in monotherapy or in combination with CTLA-4 antibodies anymore without any other type of treatment to perhaps combine and provide synergy. There are other attempts at utilizing the tumor microenvironment. Cabrolizumab is a CSF1 receptor antibody. In preclinical models, it reduces the number of immunosuppressive tumor-associated macrophages in the tumor microenvironment, facilitating immune responses against tumors. And in this study, the combination of cabrolizumab with a checkpoint inhibitor, nivolumab, did show promising activity with 10 to 15% response rates and an associated decrease in CA19-9. This has led to an ongoing phase 2 trial that's looking at the combination of cabrolizumab and nivolumab with standard chemotherapy, both gemcitabine, nab-paclitaxel, or Nal-Iri and 5-FU, versus immune therapy alone versus chemotherapy alone. So what are some of the other ongoing immunotherapy trials? A phase 3 study is ongoing, enrolling patients to FOLFOX plus or minus an interleukin-10 pegylated drug. There's a phase 2 study looking at nivolumab and ipilimumab with radiotherapy, looking at whether radiotherapy can modulate the tumor microenvironment to enhance immune therapeutic response. There's a phase 2 study looking at pembrolizumab with PEG-PH20 in pancreas cancer patients refractory to chemotherapy and having HA-high tumors. There's a Morpheus study looking at several atezolizumab-based combinations. And the phase 1b/2 Parker study looking at gemcitabine, nab-paclitaxel, nivolumab, and a CD40 agonist in the phase 2 trial. So every day in my clinic, my patients will come up to me and they'll say, "Hendafar, you seem like a nice guy. How come you don't have anything better to offer me as far as treatment for my pancreas cancer? Really, you guys can't do better." And it's probably a valid point. It's a difficult disease, and sometimes it's difficult because we can't imagine that we don't have better treatment options to offer. We're getting there, but we have a long ways to go. And probably one of the things we need to do is change the way we do research. The system as it currently stands, it takes too long to get a drug through the system, and it's very costly. And I think that sometimes impedes research and development. So this is the Precision Promise Consortium, which has put together clinical trial investigators and sites with pharmaceutical companies and patient advocacy groups. As we see here tonight, a patient advocacy group helped put this together, and some of them are also helping put clinical trials together, which is quite a remarkable thing. Now this study, the design is quite novel. It's an adaptive design that's registration ready. Here you see patients are consented to a master protocol. They get screened. If they're eligible, they get randomized. Now the randomization happens based on tumor signature, which is a complex algorithm that takes into account a lot of prognostic and predictive factors that are constantly, as the trial goes on, being reassessed. In this trial, patients are randomized to either one of two control arms or to experimental arms. The beauty is that if a trial arm is not successful, the clinical trial continues. New arms will come in, and arms that fail will leave. Patients that progress will be re-randomized in the second line as well. This is a much more efficient system, hopefully allowing for better drug development, cost savings, and some good science to go along with it. So we're excited about this. So finally, I'd like to talk about what you might find at the 2019 Asco Abstracts. There's a Mediplex study, a phase 1 study of durvalumab with pexidartinib, which is also a CSF1 receptor antagonist. There's a phase 1 trial of a claudin chimeric antigen receptor T-cell drug, which is promising for gastric and pancreatic adenocarcinoma. Definitely recommend you check that out. There's a abstract 4124, a phase 1b dose escalation study of TGF-beta receptor 1 kinase inhibitor, belzutinib, plus durvalumab in metastatic pancreas cancer. And finally, clinical and immune responses using a bispecific antibody against CD3 and EGFR for locally advanced and metastatic pancreas cancer. Okay, well, I'd like to thank you for your attention this evening.
So we'll go to casebook number 4. So this is also another Let's Win story, and I want to say this is actually a patient that we talked about last year at this time who's still benefiting from treatment. This is Rachel. She was diagnosed with metastatic pancreatic cancer in 2015. She chose not to get FOLFIRINOX and sought a second opinion. Found that she was eligible for a clinical trial, again, emphasizing the importance of clinical trials for these patients. Enrolled in the HALO 202 trial with the gem nab-paclitaxel plus PEG-PH20. She responded well to treatment and went into remission in November of 2017. And so here's her story, and here's her quote. "I have experienced some side effects, cramping due to the study drug and neuropathy. and of course fatigue, but I've tolerated these side effects pretty well. Results like mine just go to show how important it is to seek out clinical trials. So just remember Rachel, as we're thinking about how we're going to treat our patients when we see our patients when we're back in the office after ASCO, how we're going to continue to provide clinical trial options to try to advance the treatment of these patients with pancreas cancer. This is another Let's Win story with Roy, who ended up having mismatch repair deficiency in his tumor. He received pembrolizumab. His CA19-9 level is normal. He has a near complete response after his 4th infusion. And his quote, in December 2017, it was suggested I was unlikely to survive another Christmas. Now my goal is to encourage others to get genomic profiling and to help other Canadians with this mutation get access to immunotherapy. So again, really powerful statements from these patients. In light of all of that, and Dr. Hedvar's talk, I'm going to ask each of the panelists to say, okay, if you were going to put your nickel down, what are you most excited about in drug development for patients with pancreas cancer?
I'm very excited about looking at specific patient types, specifically at KRAS wild type versus KRAS mutated. I'm very fascinated by the KRAS wild type patient population. And looking at tumor stromal changes, I think we're learning so much right now, and if PEG-PH20 becomes a positive trial, it'll really change the way we treat pancreatic cancer, so I'm excited about that.
Excellent. Dr. Fishman?
So obviously I'll focus on DNA damage repair and homologous recombination, but I think that I was not necessarily a believer because I didn't really fully understand or appreciate the science behind it, but there may genuinely be something to the way in which DNA damage repair mutations cause changes in the DNA that can be immune stimulatory. And so there are some really novel, exciting trials being designed with Parp inhibitors and other DNA damage repair inhibitors in combination with some of these immune checkpoint inhibitors. And stay tuned. We don't know the results yet, but we're very hopeful.
Excellent. Dr. Kim?
I don't have a specific agent. I think that, we heard about the immune therapies and why they may or may not work. I think we really do have to keep pounding away and look at the drugs that are available. They do affect the stroma, or they do change the pharmacology. Instead of drugs just bouncing off of the stroma, they're staying in the stroma, they're getting to the tumor cells and killing them. So I think when folks are developing immunotherapies, pay attention to the stroma and pay attention to the design and the sequence of drug and then your immunotherapy. Don't just throw it all in and expect you're going to get a good result. There's a long history of negative pancreatic cancer trials. You just have to pay attention to what works and then build upon that. So,
Dr. Shroff?
Yeah, nothing that hasn't been said before, but I think what's most energizing and exciting is the fact that there are actually therapeutic options in the targeted and immunotherapy space that we can now start to think about smart combinations. And I think it goes to stromal modulation, it goes to DNA damage repair, like hitting those targets, but figuring out the synergy between those. And I think that all it takes is one patient, a BRCA patient that I had who had a BTK plus a checkpoint inhibitor and had these dramatic responses. And you see that one time and then you become a believer. And so I think that's what's exciting.
Yeah, modulating the immune microenvironment for the tumors with the cabiralizumab and the CSF1R inhibitors, CD73 inhibitors affecting the adenosine pathway, the CD40 drugs that we're seeing out there. So there's a lot of movement going on now with pancreas cancer and different immune modulators. And again, it all comes back down to that tumor microenvironment and how do we attack that well. And super excited. Most of the bang, I think, has happened with non-small cell lung cancer. I'm always jealous of non-small cell lung cancer now. It used to be breast cancer because they're getting all the attention, right? But there are specific inhibitors that are coming out right now for specific KRAS mutations, and I think you're going to be seeing those for patients with pancreatic cancer come through as well. So I think what you're hearing from the panel, here's the promise. Like, who would have thought we would have been here 5 years ago, where we're looking at multiple different sequencing for pancreas cancer, improving cure rates with adjuvant therapy, looking at specific types of mutations that might drive treatment options for these patients. Look at where we are, and then just see where we can go. So that's the really exciting part about this. And with that, I thank you all for joining us tonight.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RRU860. This activity is supported by independent educational grants from AstraZeneca, Celgene Corporation, Halozyme Therapeutics, Ipsen Biopharmaceuticals Incorporated, Merck & Company Incorporated, and Novocure. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.